Welcome. In this lecture, we'll be discussing hypertrophic cardiomyopathy. Let's first go over a brief overview of this disease. This is the second most common cause of cardiomyopathy and thus heart failure. The number one cause being dilated cardiomyopathy, which has been discussed in another video. Now, there are two primary types of hypertrophic cardiomyopathy: obstructive and non-obstructive. Obstructive type makes up roughly 70% of all cases. Non-obstructive types make up 30%. When hypertrophic cardiomyopathy is obstructive, it is known as something known as HOCM, or hypertrophic obstructive cardiomyopathy. You will sometimes use this term interchangeably and hear this in the hospital and on rotations, but there is a slight difference between those two. I just wanted to emphasize that. Hypertrophic cardiomyopathy leads to something known as a diastolic dysfunction. Remember the two phases of the cardiac cycle. Diastole is when the ventricles fill with blood, and systole is when the ventricles push that blood out into the body. If this is a diastolic issue, this is going to be a filling issue of the ventricles. This is also sometimes referred to as HFpEF, or heart failure with preserved ejection fraction. Now, why exactly do we get that preserved ejection fraction? Well, let's first discuss the pathology that is hypertrophic cardiomyopathy. This is due to something known as concentric hypertrophy, and we'll go over what this is exactly in a second. This typically leads to thickening of the ventricular septum. Remember, the ventricular septum is the area that separates the left ventricle from the right ventricle. What is occurring in concentric hypertrophy is that the sarcomeres are being added in parallel. Now, what exactly does that mean? If you remember back to your undergrad days, you learn two different types of circuits: a parallel circuit and a series circuit. Remember that the cardiac system is an electrical system, or an electrical circuit. Thus, if sarcomeres are being added in parallel, that means that they are forming a parallel circuit. This is a demonstration of what a parallel circuit looks like. Notice how these layers are being stacked right on top of one another. As we can see, because of this is causing thickening, in our case, of the ventricle or ventricular septum, thickening of that area of tissue. This is what it means to be having the sarcomeres being added in parallel. They are being stacked right on top of one another. You'll see with dilated cardiomyopathy, they'll be added in series, which will cause them to widen. The opposite is true in hypertrophic cardiomyopathy. This leads to thickening of that interventricular septum. So on the left side of the screen, we have the regular heart. Of course, on the right side, we have a hypertrophic heart. We can see here's our right ventricle, here's our left ventricle. We can see we have thickening all throughout, but more so in that interventricular septum. This is going to lead to decreased filling. So what are some big takeaway points from this slide? So they sometimes like to test you on the pathophysiology on your board exams. So this thickening of the ventricle leads to a decrease in something known as the left ventricular compliance. That is important to know. You have a decrease in compliance because of all that extra muscle. These heart muscles becomes thick and stiff, especially as we can see in the walls of the left ventricle. This reduces the heart's ability to relax, which is compliance, and fill properly during diastole. As a result, not only do we have a decreased compliance, but we get less blood that fills into the ventricle. This also leads to something known as a decrease in end diastolic volume. Despite this, the thickening of these muscles, or thickening of the heart tissue, still results in the pumping out of a large percentage of what it receives. This in turn preserves, or even sometimes can increase, something known as ejection fraction. That is how we get the terminology HFpEF, or heart failure with preserved ejection fraction. However, because the total volume that the heart is able to hold, because the end diastolic volume is decreased, the actual amount of blood that is ejected may still be low, and this leads to the symptoms. These three fundamental topics is extremely important to know for test day, as they sometimes like to ask you these questions. So now let's undergo some risk factors that can cause hypertrophic cardiomyopathy. Now, it is important to know that this can be broken down into elderly risk factors and young risk factors. The two primary causes of elderly risk factors are going to be hypertension and aortic stenosis. These are primarily doing the exact same thing. They are increasing the pressure needed in order for that left ventricle to push out blood. The body or the heart is going to respond by trying to increase or thicken the heart muscle. This leads to hypertrophic cardiomyopathy. And the reason being is because it needs more muscle, more strength to push against these high pressure systems. Now, the most common overall cause of hypertrophic cardiomyopathy is typically seen in younger individuals. This is a familial or genetic type of hypertrophic cardiomyopathy. This is what is more so referred to as HOCM, or hypertrophic obstructive cardiomyopathy. This is an autosomal dominant mutation, typically seen on chromosome 14. I've always remembered that it's chromosome 14 because this is a disease that typically affects 14-year-olds, thus telling me that it's on chromosome 14. What exactly does it affect in particular? It affects the genes that are encoding for sarcomeres, mostly the myosin binding protein C and the beta myosin heavy chain. Although step 2 and step 3 do not like to test you on enzymes and these topics that were mostly tested on step 1, it is important to know these two things, or these two things that are affected in hypertrophic cardiomyopathy. This here in younger individuals is the number one cause overall. And for the rest of the slides, we will primarily be talking about this. But it is important to know that if someone presents with something similar to what we're about to talk about, but they are roughly 60, 70, or even 80 years old, it is probably more so due to these causes. So what exactly are the symptoms that we see with hypertrophic cardiomyopathy? Well, typically in these younger individuals with this genetic predisposition, we can see syncope during exercise. That is your typical presentation, which I'm sure many of you have seen before in test questions. You'll also sometimes get dyspnea on exertion or other vague complaints such as fatigue, palpitations, or even angina. Now, the classic presentation is always going to be some sort of young individual or athlete that is going to be playing some sort of sport, and then they most likely pass out or fall down, and then they come to the hospital. But if they do not want to give you this presentation, you do want to be aware that sometimes what they'll give you in question stems is they'll give you family history of sudden cardiac death in an individual less than 40. Less than 40 years old with sudden cardiac death is important to understand because this is abnormal for sudden cardiac death. This is a younger than expected individual. Sometimes this will be the only thing you may see in a test question, and they will want you to know that this needs to be investigated further if they have someone in their family who has passed away from sudden cardiac death. Now, they'll typically also give you physical exam findings that are associated with hypertrophic cardiomyopathy. Now, comparatively to dilated cardiomyopathy, if you remember from that video, we typically see an S3 heart sound. The reverse can be said in this disease, as we typically see something known as an S4 gallop. S4 takes place right before S1. It is still occurring in diastole, just like S3. S4 is pathologic. You will also typically get a heart murmur. That heart murmur will be described to you as a crescendo, decrescendo murmur without radiation to the carotids. Hopefully this rings some bells, as HOCM is typically compared to another valvular disease. That valvular disease being aortic stenosis. So let's briefly discuss HOCM versus aortic stenosis and go over what they want you to know for test day. So HOCM is going to be autosomal dominant. Remember that. Thus, 40 is always going to be our cutoff point. We typically see HOCM in individuals less than 40 years old. Aortic stenosis, as you know, also can cause hypertrophic cardiomyopathy, more so in older individuals. This average age of onset is typically seen in individuals above the age of 60. The murmurs seen in both HOCM and aortic stenosis are going to be very similar. Crescendo, decrescendo, murmur. Typically, this occurs during systole, when the heart is contracting, and you're going to go up and down. That's a crescendo, decrescendo, murmur. The difference between these murmurs is that Hokum does not radiate to the carotids because it is not an intervascular or artery murmur. Thus, the vibration waves cannot resonate throughout the aorta and go to your carotids, where aortic stenosis is an issue with the aortic valve, which feeds into the aorta. This causes vibration waves to go through the aorta as well as the blood vessels, which can cause radiation of this sound to the carotids. This is too straightforward. They will probably never give you with or without radiation on board exams, as they want you to know typically what makes this louder and what makes these murmurs softer. The basis is off of Hokum, or hypertrophic obstructive cardiomyopathy. This is preload dependent. So I will quickly go over what increases it and what decreases it, and then I'll explain why. So typically Hokum is louder with Valsalva and standing. Remember, your Valsalva maneuver is basically like a baby throwing a temper tantrum. You're holding your breath and you're pushing really, really hard in your intra-abdominal, right? You're kind of bearing down, trying to go to the bathroom, go and take in a number 2. Standing is very self-explanatory. Both of these things are going to push the blood out of the heart. Squatting and leg raising will bring blood into the heart. Remember, Hokum is preload dependent. This is preload dependent. That means it is dependent on the amount of fluid in the heart. Now, the more fluid I have in the heart in Hokum, that's going to fill this left ventricle. And what is that going to cause? That's going to cause my ventricular septum to move and get away from my aortic outflow tract. The same thing can be true on the lateral side as well. That's going to cause my left ventricle to open up, and it's going to relieve the obstruction. If we relieve the obstruction, the murmur is going to decrease. Thus, if we increase the amount of blood in my left ventricle in Hokum, the murmur is going to decrease because the obstruction decreases. And that is exactly what this is saying. Squatting and leg raising increase the amount of blood in my left ventricle. That's going to open up that left ventricle, and it's going to decrease the sound of the murmur. The opposite can be true for things that decrease the amount of fluid in my left ventricle, such as the Valsalva maneuver and standing up. These 4 concepts, well, 2 concepts, but 4 different things, are very, very important to know for test day. The opposite can be true for aortic stenosis. Note that the Valsalva and standing soften aortic stenosis, and squatting and leg raising make it louder. Why? Because this is an interarterial or aortic valve issue. The aortic valve feeds, obviously, into the aorta, correct? So the more blood that is going to be running or flowing through or over this aortic valve, the louder the symptoms are going to be, because there is more blood that needs to get out of that left ventricle. Thus, squatting and leg raising increase the amount of blood in the left ventricle. Because there's more blood, more of it needs to be pushed out of that aortic valve. That leads to a louder sound, as there is more blood running over or through that valve. The opposite can be true for Valsalva and standing. This is a very important concept. Understanding that Hokum is preload dependent means that it gets softer with increased preload and it gets louder with decreased preload is extremely important. The last thing I want to talk about is hand grip. Hand grip is the same for both of these. Hand grip is exactly what it sounds like. You squeeze your fist really, really, really tightly. This increases your total peripheral resistance. This is going to cause more blood to flow into the left ventricle. Remember, that's going to open up this ventricle, right? So with hand grip, more blood in the left ventricle, this is going to soften the murmur of Hocum. But why does it soften aortic stenosis as well? Well, because of the fact that that hand grip is also increasing total peripheral resistance. Although I have more blood in my left ventricle, sure, what's going to also occur is that that blood isn't really going to move anywhere because the pressure gradient is going to be the same as it was on the other maneuvers in the ventricle, but now I'm increasing the total peripheral resistance. I need to form more muscle mass, more energy, contract stronger in order to push blood out of the heart. This is not going to be done in a short amount of time. That causes my aortic stenosis to also get softer, as less blood is going to flow out of that left ventricle because it is going to flow into increased total peripheral resistance. This slide is extremely important to understand and to know for test day. So how exactly do we diagnose hypertrophic obstructive cardiomyopathy? Remember, the cardiac system is very straightforward. If it's an electrical issue, such as arrhythmia, it's going to be ECG. If it's a structural issue, just like heart failure cardiomyopathy is, it's going to be with echo. This is the best test to find hypertrophic obstructive cardiomyopathy. Usually, we see HFpEF, or preserved ejection fraction. The left ventricle is going to eject at least half, or even a little bit higher, of what is in that ventricle. The issue is that we have that decreased end diastolic volume. Thus, the total amount of volume being released from that ventricle is going to be decreased. The issue is a diastolic issue. It's a filling issue. Now, something that they really want you to know, and they'll either give it to you on a test question in the STEM, and it'll scream that this is hypertrophic cardiomyopathy, or they might ask you, what may we see on echo? Is something known as a systolic anterior motion of the mitral valve. This is exactly what it sounds like. During systole, when the heart contracts, the mitral valve moves anteriorly. These leaflets move towards the interventricular septum. This results in left ventricular outflow tract obstruction. Okay? Because of this abnormal amount of mass, this causes these leaflets, these mitral valve leaflets, to move anteriorly. This also contributes to that obstruction that we're talking about. Know this. Look for this in a test question. This will scream to you that this is Hocum. You can also be pointed to Hocum in other ways. Sometimes chest x-ray is important to know. In chest x-ray, you're going to see an enlarged heart or a thickened heart. And of course, the one more commonly I feel that is given to you on test day is an ECG. Remember, ECG is not very important for structural causes, but it could be suggestive of things. This is not diagnostic, but sometimes can lead to helping in the diagnosis. What you see in hypertrophic obstructive cardiomyopathy is hypertrophy. This does not tell you the cause. This does not tell you exactly what's going on, where the issue lies, but it does lead us to think Hocum. You're going to see these tall R waves. See V1, V2, V3. These are extremely tall R waves. They're actually overlapping with one another. We have these tall R waves because of the increased thickness in the ventricle. You need more depolarization in order to initiate a contraction. That is exactly what this is telling you. Look how large all these are. You need more calcium channel opened, more depolarization to undergo in order for contraction. This screams out hypertrophy. Remember, this does not tell you what the cause is, as just baseline hypertension causes as well. But this can sometimes be given to you on test day to point you in the right direction. So let's kind of sidebar this and talk about screening. Screening for Hocum is highly tested because of the fact that the autosomal dominant cause is the most common. This is done with an echocardiogram, nothing more, nothing less. And what you're looking for is all the signs of HOCM. You want to catch it before it causes an issue. So what are the indications for it? Now, there are 4 indications, okay? First or second degree relative with sudden cardiac death in someone less than 40. This has been brought up multiple times throughout this lecture. This is something that I cannot stress enough that is highly important. If you have a first degree relative who has suddenly passed away at the age of 30 from some sort of cardiac failure, you need to be screened for HOCM. Now, there are other causes: individuals with family history, individuals experience symptoms, individuals with a heart murmur or abnormal EEG. This is great to memorize, but what is this telling you? This is telling you, hey, you have symptoms or your family has a history. That's all these indications say. So you screen someone, obviously, if you have symptoms, right? We just talked about that. But also, if you have a family history. This first one is the one that I would definitely just commit to memory. Look for individuals with a family history of someone who passed away less than 40 years old. Those individuals need an echo no matter what. So how do we treat HOCM? Let's first go over medical treatment. Medical treatment for HOCM is very, very straightforward. Remember, this is typically for autosomal dominant, but it can also be used for older individuals due to hypertension or aortic stenosis. So we typically want to avoid volume depletion. Remember, this is preload dependent. IV fluids increase the preload. So if someone comes into the hospital and they ask you what is the next best step to give these individuals, it's always going to be IV fluids. You want to limit the amount of fluid depletion that they have. So you avoid volume depletion. Beta blockers is going to be the best initial medication to give. This is given for symptomatic patients, okay? Beta blockers is the best initial medication. IV fluids is the best first step. There's a big difference there. Those are key words that they like to chime you in on test day. And of course, if beta blockers are contraindicated for whatever reason, or they do not work, we can use calcium channel blockers. Typically stuff like verapamil, okay, these non-dyes, dihydropines that we use, not stuff like amlodipine and those kind of medications. So this treatment options are more or less straightforward. Where they're going to get you is what's the next best step. In that case, it's IV fluids. What's the best treatment option? That's going to be beta blockers. Okay? Now let's talk about operative treatments. The operative treatments are going to be something known as an ICD. If you watch the video on dilated cardiomyopathy, we use something known as an AICD. Heart failure and cardiomyopathies need some sort of defibrillators. So who gets a defibrillator? These are done to those with a history of syncope or events seen on Holter monitor. Those individuals that are coming in with symptoms and those question stems, they need an ICD. Remember, that's not always going to be your clinical presentation. Sometimes you'll just be given, this person comes to your office, they're asymptomatic, their father passed away at the age of 30 from sudden cardiac death. That person needs to be screened for HOCM. It's important to know that we have to give an ICD because the number one cause of death is not syncope. It's going to be these ventricular arrhythmias that can occur. That is why we give an ICD, a defibrillator, in order to shock them just in case they go into one of these arrhythmias. This is important as a lot of people with HOCM do need to have some sort of ICD placement. You give those to individuals with a history of symptoms such as syncope or events, ventricular arrhythmias seen on Holter monitor. You can also even sometimes do something known as a surgical septal myotomy. This is only done really if the heart failure symptoms persist even despite medical management. So this is kind of your last ditch option, okay? This is, you literally just go in and you kind of just take the muscle away from that interventricular, leading to an opening up of that outflow tract, okay? This is your last option out of all of these. This will not be the next best step, etc., etc. This will be your last option. So this is hypertrophic obstructive cardiomyopathy. Now, what exactly do they like to compare this to? Something known as anomalous aortic origin of a coronary artery. Maybe you've heard of this, maybe you've not. We'll briefly go over the pathology. It's definitely not as high yield and not typically tested on the pathology aspect. There are two things that are typically asked about this complication though. So what happens is you have this sharp curvature from an anomalous coronary artery. This sharp curvature leads to the inability to withstand high outputs during exercise. So you're going to get a very classic presentation, someone who has syncope when they're running on the soccer pitch or something like that. Now, here's an image. All of these are abnormal. This up here is obviously normal. What we can see is, if you look here, if you can see my drawing, and you look here, you can see that there's the carotid arteries that come off of this aortic valve typically come off pretty straight, which is good. This means that these arteries can handle high blood flow. Now the issue is, if when you have this anomalous origin in either the right or left aortic sinus, you can see how sharp of a curvature these are coming off of the aortic valve. That is hopefully you guys can see that, but that sharp curvature cannot withstand high outputs. It blocks itself. This leads to all of the symptoms of this disease. AKA, this leads to an outflow obstruction, just like Holcomb does. So the symptoms will occur in a young individual, because this is something you're born with. We'll pretty much catch those early on. You'll have syncope with exertion. You'll have dyspnea on exertion, lightheadedness, angina, etc. Exact same presentation as Holcomb. The difference here is this individual will not have a family history of cardiac death in an individual less than 40. Remember that less than 40. That's important. Sometimes they will give you that they do have a history of sudden cardiac death, but that individual will be 55, 65 years old. That is not an abnormal thing to occur in someone's life. But if it occurs in an individual less than 40, that is telling you, hey, this is Holcomb. How do we diagnose this? Well, let's go over what they're going to give you in a question stem. The echo and the ECG will both be normal. Echo to rule out Holcomb, ECG to rule out arrhythmias, such as, let's say, Wolff-Parkinson-White. So how exactly do you diagnose this? You use something known as the CT or MRI angiography. You look for blood flow or blood tract issues. What are they going to ask you on the exam? They're going to ask you, how do you diagnose this? Or they're going to ask you, what is this disease? You're looking for someone who presents just like Holcomb. They do not have a family history of someone less than 40 years old with sudden cardiac death, and their imaging will all be normal. The way that we diagnose this is we look at their blood vessels with a CT coronary angiography, or we compare it to Holcomb and we know what this disease is now. Let's go over one last high testing point, high yield testing point, something known as high output heart failure. This is exactly what it sounds like. This is heart failure with high output, aka heart failure with more than usual ejection fraction. That's a good way to put it. So what happens is that we have stress throughout the body, peripherally, and this causes an increase in demand for blood flow. This leads to high cardiac output and a decrease in the total peripheral resistance, aka the systemic vascular resistance. Those are the exact same thing. Do not get that confused. High cardiac output and a decrease in your systemic resistance. That's going to lead to even more cardiac output. So what causes this? AV shunts can cause this, an arteriovenous shunt. Severe anemia. Anemia is going to lead to decreased oxygen delivery to tissues. Your body's going to respond to, hey, I need to increase my amount of blood going out of my heart in order to respond to that. Thyrotoxicosis, everything is overactive in thyrotoxicosis. Same thing with hyperthyroidism. These go hand in hand, obviously. Okay, and then wet beriberi. If you remember back to your dilated cardiomyopathy lecture, wet beriberi can also cause dilated cardiomyopathy, but sometimes thiamine deficiency is more so associated with high output heart failure, but they can also be seen in both. It is important to know for AV shunts, size of that AV shunt is the most predictive variable for onset of heart failure. Larger AV fistulas lead to an increase in venous return, and those in turn lead to high cardiac output flow from that increased venous return. So what are the symptoms we're going to see in high output heart failure? You're going to have widened pulse pressure. Pulse pressure is easily calculated by systolic blood pressure minus diastolic blood pressure. Anything greater than 65 is thought to be a widened pulse pressure. If someone's systolic is 140 and their diastolic is 60, the difference there is going to be 80. That's a widened pulse pressure. Shortness of breath, fluid overload, brisk carotid upstroke is very important as well, or bounding pulses on exam. This occurs due to that increased amount of blood leaving the heart. And then, of course, symptoms relate to the underlying cause. In severe anemia, you're going to see anemia in lab values. Thyrotoxicosis, you're going to have sweating, you're going to have nausea, you're going to have diarrhea, you're going to have a high T4 or a low TSH. Wet beriberi, they're going to have a history of chronic alcoholism or severe malnutrition. They're going to maybe have Wernicke's, confusion, altered mental status, ocular changes. Be on the lookout for that on exam day. So what are they going to ask you? They're going to ask you about the physiological changes that occur in high output heart failure. There are three primary ones. There are increased PCWP or wedge pressure. This is basically saying, hey, we have increased pressure in the lungs, sure, but more so in the left atrium. Increased cardiac index. Cardiac index is a fancy way of saying cardiac outflow, which we already know that increases because it's a high output heart failure. And then, of course, as we already went over in up here, we have a decreased total peripheral resistance. That decreased peripheral resistance occurs in order for my body to try and deliver more blood as it thinks it needs it. Understand these three physiological changes that occur in high output heart failure. You treat it based off treating the underlying conditions. That concludes this lecture on hypertrophic cardiomyopathy.